All right, hello and good afternoon, everyone. We are very excited to kick off today's program, which will focus on risk reduction and improved outcomes through patient optimization as it relates to transplant nutrition. My name is Deanna Fenton, Program Manager here at the Alliance, and it's my pleasure to welcome you all here today. Now, we know this has been a huge topic of conversation within the transplant community, so I'm sure we're all very eager and excited to get started. But before we do, I'd like to quickly review a few housekeeping items and reminders with all of you today. Now, for those of you who are joining us for the very first time, we ask that you take note of our Q&A feature that's located at the bottom of your screen in the Zoom navigation bar. All of your questions for our presenters should be submitted here. Now, for those of you who submitted questions during the registration process, please know that we've done our best to compile your questions and we'll have our speakers address them throughout the course of the presentation. Now, should you have any additional questions, please feel free to submit them using this Q&A box. Once the presentation has concluded, we'll go ahead and transition to our Q&A discussion, where our presenters will address as many of your questions as time allows. Now, additionally, for those of you who are joining us as a group, please take note of the following poll that I'm launching. There we go. For those of you who are participating in a group and using this as a group learning opportunity, we ask that you complete this poll to indicate how many people are participating in your respective group. Your responses will help us and our two presenters gauge the level of participation and engagement in today's program. Now, for anyone interested in our upcoming webinars, please note that registration is still open for our very first innovation webinar of the year. So you can join us to hear from a panel of OPO and transplant leaders who will highlight successful workforce models in a virtual environment. Tune in for that next Tuesday on March 30th at 2 p.m. Eastern. Additionally, registration is currently open for our next donation-focused webinar, which will highlight donor management snags and how to overcome unique challenges impacting our OPO colleagues. We encourage you to join us for that on April 6th at 2 p.m. Eastern. For more information on either program and to stay up to date on all of our upcoming programs, please visit our website at organdonationalliance.org. Now, following the conclusion of today's program, you are all eligible to claim continuing education credits. For this webinar, we will be offering 1 CEP-C credit and 1 nursing contact hour. Now, also given the nature of this webinar, we will be adding one registered dietitian, CPEU, for your participation in today's program. And as always, there is a certificate of attendance that's available for those of you who are seeking CEs that may not be offered. Now, prior to receiving your credits and certificates, you will all be asked to complete a brief online evaluation that will allow you an opportunity to give us your valuable feedback. If you happen to be listening in a group, please be sure to get your evaluation email from your group lead. As a friendly reminder, you'll have 30 calendar days to complete your evaluations and claim your credits. Now, without further ado, I'd like to go ahead and begin today's program by introducing our moderator, Mariana Tosi, registered dietitian at NYU Langone Health. Mariana, thank you so much for joining us today. And at this point, I'll go ahead and turn the floor over to you.
All right. Okay, thank you so much. So my name's Mariana. I'm a dietitian at NYU, working with their transplant team. I am so excited to introduce our two great speakers. One is the past.
Sorry, I think your audio is cutting out a bit.
Oh, can you hear me?
I can hear you now, yes.
Okay. Dr. Mueller is the past president of our National Board of Nutrition Support Certification, where he implemented a single certification exam in nutrition support practice for all health professions. He was also a commissioner on CDR, chair of its exam committee, and most recently on a CDR task force charged with validating the need for and creating a process for obtaining an advanced practice credential for dietitians and nutritionists. He has been a consultant to the clinical nutrition industry, as well as the consulting practitioner for home parenteral nutrition. He currently serves as the board of the Aspen Roads Research Foundation. Dr. Mueller's research has included the outcomes of enteral tube feeds in elderly long-term care residents and the effect of weight loss interventions on cardiovascular disease risk factors. He's published in the peer-reviewed clinical journals and a frequent speaker on the local and national levels, as well as an associate editor and reviewer for several peer-reviewed clinical nutrition journals. And on a personal note, I just have to say he's done a lot for our profession, so I'm very excited that we've been able to hook up with him and have him present for us today. Our second speaker is Courtney Dunn. She's a dietitian at the UCSD Healthy Lung Transplant Program. Courtney and I used to be coworkers, and so I can attest to her knowledge, breadth of knowledge, and her amazing skills as a dietitian. She has over 8 years of experience as a clinical dietitian, taking her skills to several large academic medical centers throughout the country. For the past several years, she's been working with the transplant population, and most recently as the lung transplant dietitian at UC San Diego Health. Courtney holds a board certification in nutrition support, and she provides quality, up-to-date, and evidence-based care to her lung transplant patients throughout their transplant process. So I'd like to have Dr. Mueller start us off with his talk, and thank you so much.
Thanks, Marianne, and thanks, Deanna. This is kind of fun to be giving a talk from my little living room chair. So I'm thrilled to be here, and I'm going to try to link malnutrition, our current understanding of malnutrition, to be able to apply it to transplant populations. To do so, we do have to understand what malnutrition is, because it's been a moving target for decades. So bring you up to date. And then I'm going to quickly go through nutrition-focused physical examination, because actually an examination can distinguish between the different types of malnutrition. There are a couple of very frank attributes that can help you distinguish. And then I'll try to apply them to the transplant population. I am not an expert in transplant. I only know the big picture. So I hope I will do justice to your practices. So a definition of malnutrition is it's an acute, subacute, or chronic state of nutrition in which there are varying degrees of over or undernutrition with or without inflammatory activity, and they've led to change in body composition and diminished function. And we're really talking principally about undernutrition. We're not going to be talking about overnutrition, although we are going to briefly talk about sarcopenia to distinguish it from cachexia. So what is malnutrition historically? We learned in school, most of us, it's protein, calorie malnutrition. We use this terminology, marasmus and Kwashiorkor, is really very outdated, you guys. Not the clinical syndromes that have been described, but the causes of marasmus and Kwashiorkor. So I'm going to try to distinguish them for you, because they really have been distinguished by the etiology-based definitions, which have recently been updated a little bit in the GLIM publication. So we're going to go through the history a little bit. Now, right away, I noticed this morning. These two words should be switched around when I was reformatting this slide a week ago. Absent should be over here and present should be over here, okay? This is from 1970 in The Lancet, noting that what was the difference and degree of difference between Kwashiorkor and marasmus, how undernourished, very undernourished, and by presence of edema, okay? So when edema is absent and you've lost this amount of weight, you have marasmus, and when present, you have Kwashiorkor. So the distinguishing feature between marasmus and Kwashiorkor is edema. And this is from 1972, British Medical Journal. Kwashiorkor results from a deficiency of protein with relatively adequate energy supply, whereas marasmus is caused by an overall deficiency of protein and energy. The clinical characteristics of marasmus are emaciation, state, weak, bradycardic, hypotensive, low temperature, dry skin, ravenously hungry with normal mental status. So hunger is present with marasmus. Kwashiorkor, and look, this definition dates from 1933. It derives from a mom in Ghana used to describe the disease in their children, the disease of the first son when the second son is born. Notice they say son. It's 1933. I guess daughters don't matter, but it's 1933, and it reflects the association between Kwashiorkor and the weaning process from protein-rich mother's milk to a grain-based diet. This is what was thought to be the etiology of Kwashiorkor in 1933. These people, and this is a legitimate description of Kwashiorkor, they're anorexic. They do not have an appetite. They're moon-faced. They have anasarca, usually, edema all over the body. They have hepatomegaly, hepatic steatosis, really, we understand now. Big bellies, perhaps ascites. They're irritable, and of course, they're susceptible to infection. They look like this. Here's the same child, renourished and treated, which I'll talk about in a minute. And you can see he has that moon-shaped face. He has the protuberant belly, and you can't probably see the edema in his arm. Here is the marasmic child, emaciated, but no edema. Here they are compared in a cartoon. Here's the Kwashiorkor-like child. Here is the marasmic child. A pediatrician, and I was guest editing a issue of Topics in Clinical Nutrition, became fascinated by the fact that I used to say Kwashiorkor is totally misunderstood, and it's really not a condition of malnutrition or protein malnutrition at all. And she looked into it and did a literature review, and her major bullet points was that, well, Kwashiorkor has been reported in breastfed infants, and study reports resolution of edema before albumin levels are normalized. And Kwashiorkor seems to be associated with chronic infection, HIV, tuberculosis, dysentery outbreak, aflatoxin poisoning. And she concluded that there is a strong likelihood for the role of inflammation, systemic inflammation in Kwashiorkor. So from these definitions, we have developed a lot of paradigms in the 1960s, 70s, and 80s, and into the 90s. When I was training, I was told that we could evaluate somebody's visceral protein stores. And I thought, what's that? And they happen to be prealbumin, albumin, and retinol binding protein. And I was taught that when they're low, it's like a measurement on a gas meter, and that we could replete protein, we could replete prealbumin and albumin by giving more protein. And we also had these, and would also preserve lean body mass if we gave them adequate nutrition and protein. And we wrote a paper in 2004, some colleagues of mine, Patricia Furman and Pam Charney and myself, we really got sick of the transport proteins being linked to malnutrition or protein malnutrition alone. And we found that historically a large literature associated nutritional status, that is to say, poor oral intake and weight loss with transport proteins levels. Well, when your transport protein levels are low, you have a low appetite. Okay, and you're losing weight. So it was thought that there's some kind of connection. You're not eating and the transport protein levels are low. So when serum levels are low, supplementation, aggressive nutrition will treat. But was this really cause and effect? More recently, another group of literature, and some other paradigms, I'll get into that next. Do people lose significant amount of weight on diets have low albumin? Okay, if you lose 20 pounds in 2 months, will you have a low albumin? The answer is no. Do people with anorexia nervosa have a low albumin? No, it's normal. Why does a well-nourished person post-trauma in the ICU 2 days later have an albumin of 2.0? Are they malnourished? Okay. Why does an acutely ill patient who's lost a few pounds in a couple of weeks have an albumin of 2.8 or 2.2? Usually they have cancer and it hasn't been diagnosed yet. So we noticed that 12 studies correlated serum protein concentrations with duration of nutrition support, anthropometrics, comorbidity, and mortality, and assume that nutrition is the primary causative factor. So low serum proteins concentrations correlate with poor outcome. We just have to treat these low levels and we'll improve outcome. Later studies noticed that, what these serum protein concentrations correlate with are not only morbidity and mortality, but also a rise in some very significant inflammatory markers. And they conclude that inflammation, that is systemic inflammation, both acute and chronic, is the primary causative variable in the decrease in transport proteins. In 2005, I gave a presentation at Aspen conference that just happened this weekend. And a lot of people got very mad at me because I wanted to get rid of these definitions. And I said, we really should distinguish patients between those who have uncomplicated malnutrition, that is to say starvation, okay? And they are distinguished from people who have disease-related malnutrition. And in that group, you have altered metabolism. People with disease-related malnutrition do not have anabolic capability, okay? We all have anabolic capability, right? In the morning, we're catabolic, we eat, we're anabolic. Not so with chronically ill people. They are catabolic until you get rid of the stimulation of the systemic inflammation. And lo and behold, 5 years later, Gordon Jensen and a group from Aspen, all who I know well, I was feeding them information and so thrilled with what they were doing with a group of Europeans. And they created 3 new categories, 3 new definitions or different categories of malnutrition. One was this starvation-related malnutrition, and then they have one for chronic disease-related and acute disease-related. And they give examples. This is chronic starvation without inflammation. These 2 have inflammation. The chronic people are probably those with, cancer cachexia, and people waiting for organ transplants, heart failure, end-stage heart disease, end-stage renal disease, end-stage liver disease. All of them have chronic disease, organ failure, and they are prone to cachexia. And then the acute disease related, this is the ICU. This is the COVID patient in the ICU, or the 2/3 full body surface area thickness burn patient. I created this continuum, and if you all know the C-reactive protein is the inflammatory indicator. Most of you are all familiar with that. And if on the y-axis you could plot C-reactive protein, you can pretty much make a continuum of normal metabolism, chronic inflammation, and severe inflammation. And this normal metabolism correlates with the group that would be capable of anabolic, catabolic metabolism, and if they didn't eat enough, would have simple starvation. You move to chronic inflammation, and these people have degrees of C-reactive protein from 0 to about 15 up here. Obesity alone, most people have a C-reactive protein of about 2 to 3. Put in diabetes type 2, it goes up to 3 to 4. And indeed, those are indicators that you're more likely to have a cardiovascular event. They predict a cardiovascular event better than LDL cholesterol. But regular human metabolism is maintained. Here we have chronic systemic inflammation from chronic disease. Here we have acute and severe systemic inflammation from critical illness, organ failure, and these are the people who are the sickest in the ICU, and their C-reactive proteins go up to 100, 200, 300. It's double digit here. And these represent these three categories of malnutrition. And here is a slide that I absolutely demand my students learn at all levels of my teaching, and that is the difference between starvation, chronic disease-related malnutrition, and acute. I use the words cachexia and acute critical illness or trauma. Here, starvation, decreased basal metabolic rate, you mobilize fat and protein, but over time, you're in a self-preservation mode, you decrease your mobilization somewhat. And from oxidation of fatty acids, you produce ketones. Here, normal or increased BMR, not decreased, and increased protein breakdown, okay? And this is the same thing, only magnified. When you feed this group here, they can go from catabolism to anabolism, just like us in the morning. These two groups, no, not capable of anabolic metabolism, and no ketosis. People with cachexia eat no food, eat 500 calories a day, they don't get ketotic, okay? Very different metabolism. Here is probably your organ transplant patient. Here is probably your post-transplant patient, okay? And maybe later on in recovery, they return to normal metabolism sometime after their transplants. But this is so important to understand, so important to understand. I'm going to speed along. We have some consensus papers that was published in 2012 in the formerly called the Journal of the American Dietetic Association to look for attributes of the three different acute, chronic, and starvation-related malnutrition categories. Still not very good because these folks have, these folks have lots of variability in weight because they really third space fluid a lot. This is wrong here. In starvation metabolism, nobody third spaces fluid. You don't get edema if you're merely starving. You really only get edema if you're sick or you have organ failure, okay? And then these definitions that I showed you, the three quickly were updated in 2019, and they have fine-tuned the chronic disease-related group. For instance, rheumatoid arthritis can be both cachectic and non-cachectic. There are some people with rheumatoid arthritis who have relatively normal catabolic anabolic metabolism when fed, but then there are a group of people with rheumatoid arthritis who are always catabolic. And so we have divided this group up a little bit and kept this group the same. And criteria to establish malnutrition using the GLIM model goes through this progression using a screening tool for malnutrition risk. And there should be another circle down here in this figure to check. And then checking these off: phenotype, do they have weight loss, body mass, reduced muscle mass, etiology, do they have reduced food intake, do they have an inflammatory condition? And they just have to meet one of each category for a malnutrition diagnosis, and then you can determine its severity. So it's a more refined model than the previous one. And let me emphasize that anorexia and edema are findings associated with inflammation and with systemic inflammation, and therefore acute and chronic disease-related malnutrition. When you have an anorexic person in front of you who looks malnourished and or has edema, they probably have a disease process going on. They are not merely undernourished. And the outcomes of your treatment are going to be very different than merely putting weight on or restoring lean body mass. In fact, the World Health Organization triages children. They are basically triaging children to Kwashiorkor or marasmus, okay? Severe acute malnutrition triaged by the presence of bilateral edema and presence of appetite in addition to evidence of a disease process. Those children who do not have edema and pass the appetite test just need a supplement. They just need food. Those children with edema, when they call it nutritional edema, must be brought to a clinic to be evaluated for a disease process. These are the marasmic children. Okay, excuse me. These are the marasmic children. These are the Kwashiorkor children. This is in practice, World Health Organization, since 2013. And I'm going to review this slide, and then I'm going to go whizzing by, and for time's sake, a bunch of slides describing inflammatory metabolism. But it's normal. When you get a little cut on your hand, it's local, it swells, white cells come rushing to the cut, you heal it. That's all an inflammation process, but it's local, okay? It's a normal immune response. You get a cold, you have immune response, et cetera, okay? But it can get really serious. And I'm sure you've heard of SIRS. I have a colon here because my students, I want them to say, what is SIRS? Most of you probably know this is systemic inflammatory response syndrome, which is a common terminology used in ICU settings. This is out of control systemic inflammation in the ICU setting. Now, for those of you who are interested, you can look at how it's controlled on the cellular level, the inflammatory mechanisms, but we don't have time. But it is under control. There is a genetic influence. Not all of us will express inflammation exactly to the same degree, given the same insult. So there is a genetic predisposition to it. And what is inflammation for? Well, human beings are exquisitely evolved for self-preservation. We live off of ourselves when we get very sick. We literally cannibalize ourselves, our muscle mass. And our muscle mass provides substrate for wound healing, for immunoglobulins, for enzymes, for clotting factors. And indeed, muscle mass predicts outcome probably better than from severe illness, probably better than anything, okay? So these next slides really describe carbohydrate, protein, and lipid metabolism during systemic inflammation. And the change in protein metabolism that goes on, that is mediated or happens in the liver. And we define what happens in the liver in this change in protein metabolism in the acute phase as positive and negative acute phase proteins. The negative, and these are the transport proteins, their synthesis decreases at least 25%. These proteins release their ligands, hormones, calcium, iron, et cetera, and you have increased tissue uptake, presumably for the inflammatory response. But these are a list of those proteins. Here are the positive acute phase proteins, and their synthesis increases. There's C-reactive protein, which functions in the communication of lymphocytes. All of these proteins are involved in clotting to stop bleeding and so on and so forth. So we prioritize the type of proteins we make during systemic inflammation. All mediated by cytokines. And you can look at what each one does. Shock, cardiac output decreases. But let me show you this one. IL-2, look at capillary permeability. That's what causes edema, okay, capillary leak. And I'm gonna go back. This is what makes you lose your appetite as well. Interleukin-1, action on the hypothalamus, that's what kills your appetite during systemic inflammation, and so on and so forth. And then this is what I learned in the 1980s. We didn't know that neuroendocrine activation was stimulated by cytokines, but cytokines stimulate corticotropin in the pituitary, which stimulates the adrenal cortex to produce cortisol and aldosterone. And then there's a feedback mechanism. And eventually we have the catecholamines, which cause catabolism. produced in large quantity. And this is endocrinology. And that's basically what this slide shows you. This is the hypopituitary adrenal axis, and this is the hypopituitary thyroid axis. And this downstream effect of both ends in the production of catecholamines, catabolic hormones. And there are other mediators. And there's a compensatory response. There are a number of cytokines that turn the whole thing off. And in fact, we're never quite sure in the ICU setting which one is dominating, inhibition or stimulation. And here's this inflammatory continuum again. Here is this metabolism again. So important to understand. Here is the terminologies, systemic inflammatory response syndrome, which looks very different in trauma, very serious pancreatitis, advanced cancer, and other chronic diseases and conditions. It derives from gram-negative sepsis, the terminology. Most recently, in the New England Journal of Medicine, we saw in the press this terminology, cytokine storm. And cytokine storm is basically systemic inflammation. And you can look at its clinical characteristics in the very sick patient. This is from the New England Journal. But do note, all of the things that go on, hepatomegaly that are similar to acute inflammation, organ failure. Here's capillary leak, right, causing edema. Most of you might know that the sickest patients in the ICU just blow up in front of you with extracellular fluid volume. And then here's anorexia over here. Nothing new about the cytokine storm for people who really understand systemic inflammation. Cancer, anorexia, and cachexia. So cachexia is a syndrome that accompanies a lot of diseases, including organ failure, cancer, active AIDS, okay? And it really is a condition. It is a condition like that middle box in the table of obligatory catabolism, and you can't feed somebody out of it. You cannot feed somebody out of it, meaning you cannot put muscle mass back on somebody who has cachexia and active disease. You have to get rid of the disease. In the case of organ transplant, you have to transplant the organ. And here are all the characteristics, and this comes from a cachexia scoring tool that's used in oncology. But these are all attributes of chronic inflammation. It's a great tool to understand chronic inflammation. Now you have to distinguish this from sarcopenia. I can't stand it when somebody says, oh, they have the sarcopenia of end-stage liver disease. And I go, no, that's cachexia, okay? Sarcopenia is reduction of muscle mass and function associated with age, reduction of protein synthesis and deregulation. Is it early cell death among muscle cells? And it results in frailty and weakness. It is a function of age. It is very different and can be caused by a lot of things, but most of this has to do with age. And in terms of, here's more cause, so we'll go whizzing by this. I hope you have access to slides if you want to look into this in more detail. And cachexia is not sarcopenia. It looks like it often, but cachexia is a metabolic syndrome which inflammation is the key factor, and sarcopenia is a geriatric syndrome and focuses on muscle mass and function. And treatment approach underlies the differences. This is the incidence of sarcopenia, because there are lots of old people. Here's the incidence of cachexia. Here's malnutrition, but you can have all three. Okay, some overlap, but they are different. And when you kind of have to distinguish between the two. In terms of treatment, resistance training, okay, works. An older adult, you can send them to the gym and have them lift weights and they'll increase their muscle mass with sarcopenia and obesity. And here are some of the mechanisms that might be responsible. Protein supplementation above adequacy, say 1.1 to 1.2 in adults, which most of the literature says, does not improve muscle mass in people with sarcopenia. So you want protein adequacy plus exercise. Not so in disease-related malnutrition. Cachexia, you really can't increase muscle mass, not by more protein and not by, right? And not by exercise. And of course, they don't feel like exercising anyway. So we apply all of these things that dietitians know about, meals, so on and so forth. Breakfast sometimes is a good time to feed. It's not to say that we aren't feeding the acute phase response, all right? But we have to throw out that idea that we can preserve or increase muscle mass with nutrition, with systemic inflammation. Oh, we may increase survival. We may decrease incidence of infection. We may get people off of mechanical ventilation more quickly, but we don't preserve muscle mass. At least not yet. And then we can use pharmacology, which many of you know about. And that's what this goes through: anabolic agents, testosterone derivatives, MEG-ACE, that'll come in here. Okay, appetite stimulants. This is what we use with cachexia. Their flew in there, marijuana. Most of you know that steroids increase appetite. And in the acute, in the ICU setting, we're very conservative now with energy prescription, a little more liberal with protein, mixed lipid sources. Soy-based lipids appear to be a little bit immunosuppressive, so we limit their use to less than a gram per kilogram per day. The timing, where there is even evidence that we perhaps shouldn't be feeding people in the acute phase of inflammation in ICU because it inhibits something called autophagy, which is the clearing of metabolic waste due to systemic inflammation. There's a large literature in the last couple of years of the inhibition of autophagy, which is why it seems that people who receive very conservative amounts of calories, who are critically ill, do better than those who are fed, say, adequacy, 30 calories. So maybe we should be giving them 20 calories instead of 30 calories per kilogram. Maybe we shouldn't be feeding them at all in the first few days of admission. And here again, for emphasis, is this triaging of children in the treatment of the really emphasizing the difference between starvation and inflammation related malnutrition. Now, I don't have time, so I'm going to go whizzing by the nutrition focused physical exam, but I have slides that give you some of its history, starting in the 1990s. But here, pay attention to this slide, and out at Rutgers, Dr. Taubert Decker, Riva's group, has done a lot of work with nutrition-focused physical exam, and it involves skills focusing on vital signs, head, neck, and oral exam, swallowing, skin exam, body composition, maybe heart and lung sounds, and definitely an abdominal exam. I used to do abdominal exams in the early and middle 1990s to evaluate when to start diets on people. Gastroenterologists taught me how to do it. I used to listen to lungs too on a parenteral nutrition team because I was always looking for pulmonary edema, which has a very distinctive sign. But these are the basic skills, whether it's entry level or advanced level. And the techniques are inspection, palpation, percussion, and auscultation. Here are definitions of each. You're probably familiar with them. We teach these skills at NYU to our dietetic interns. But we're going to probably, as nutritionists, concentrate mostly on muscle, skin, and edema. We're going to be looking at muscle mass and third spacing of fluid. How much are they depleted? Edema, yes or no? It's going to tell you what kind of malnutrition they have. And these are just pictures that take you through it. You can see it in the head area. You can see it in the Bichat's pad underneath the cheekbone. You can see it in the clavicles. You can see it in the legs. Fluid accumulation, you can learn, it can happen everywhere. Brain, eyes, ears, lungs, pulmonary edema, arms, legs. This is what you see. You need a couple of liters of fluid to just begin to see ascites in the third space in the abdomen. You can have, this is really gross, scrotal edema, feet, pedal edema. And you know, pitting edema can be quantified, and you can assess ascites. I always say ascites, when you move somebody around that has it, it's like a water balloon. Everything sloshes to one side. Now I've reached the end. So how does somebody who knows nothing about transplants apply this to a transplant population? Well, bone marrow and stem cell, I think, is a special group because the pre-transplant ablative treatments are harrowing or not so harrowing. The non-ablative treatments versus the ablative. The ablative, you can fry your gastrointestinal tract so much that you have to go on parenteral nutrition. Well, I think we're talking mostly about solid organ transplant to this group: cardiopulmonary, liver, kidney, GI. And I would sort of isolate into the pre-transplant, post-acute, and chronic. And pre-transplant, organ dysfunction and failure, chronic disease-related malnutrition, immune and metabolic dysregulation, anorexia, cachexia. You're not going to preserve muscle mass, you guys. And I would never delay transplant. A surgeon says to me, let's replete them for 2 weeks. I'd say, no. Let's transplant them right away and feed them aggressively post-transplant if we have to. Because you're not going to preserve lean body mass by waiting. You're just going to lose more of it. The acute post-transplant is probably like the ICU patient. It's that third category. They're very of course, they're going to be, all transplant patients are immunosuppressed, but they're very catabolic. They won't eat anything, okay? Now, I suppose the post-transplant phase depends on the transplant, whether they have to be in the ICU setting. But they are sort of in this category. To the degree that they recover, then they can always be immunosuppressed because, of course, drugs are used to immunosuppress them so they don't reject their graft. But eventually they will return to normal organ function. They will return to have anabolic capability. So they have to eat adequately and they have to get physical therapy and exercise. And they are at the highest risk of refeeding syndrome at that point because they're anabolic. Refeeding syndrome is always on the table when somebody has anabolic capability, not catabolic, but anabolic capability. Refeeding doesn't really happen in cachexia because they're breaking down tissue. They're not making it, okay? That's my quick and very dirty application of malnutrition to transplant. So I think we can go on to our next speaker, who knows more about herself than I do.
Thank you, Dr. Mueller. We're going to go ahead and turn it over to Courtney, but I just wanted to give a quick heads up to everyone. We are running a bit low on time, so I just want to let you all know that we will do our best to get to the Q&A. So if you're able to hang on with us, that would be great. But at this point, I'll go ahead and turn it over to Courtney, who will walk us through her portion of the presentation. Thank you, everyone.
Mueller. Okay, so today I'm just going to be reviewing the nutrition focused physical exam briefly, and then the transplant nutrition assessment. So no disclosures and the objectives. We've already discussed how to perform the nutrition focused physical exam and identify muscle and fat losses. But we're also going to discuss how to incorporate the nutrition focused physical exam into caring for transplant patients and our transplant nutrition assessment. Okay, oh, sorry. So considerations when you're performing the nutrition-focused physical exam, this can be done in an inpatient setting as well as the transplant nutrition clinic. I've done it in both situations. I've also started to use an abbreviated version on virtual visits now that we're in a COVID world and a lot of our transplant clinic patients had to be moved to virtual. So prior to performing the exam, I just ask the patient for consent. I explain why I need to perform the exam. And then I make sure that we're in a private space. So if there's a shared patient room, drawing the curtain and also closing the door. Just make sure to practice proper hand hygiene prior to performing the exam, also wearing proper PPE, and then cleaning any patient or any instruments that might be shared between patients. And from the nutrition-focused physical exam, I take those findings and I communicate them with the transplant team and document them in my transplant nutrition assessment. So components of the exam, as we've talked about, but mainly how the nutrition-focused physical exam can fit into our transplant assessment. So it's a general survey of the patient. We're assessing body habitus and BMI, which those two factors can be useful in determining whether or not a patient can be a candidate for transplant. So all transplant centers will have BMI criteria for their candidates, and then that criteria will also depend on which organ is being transplanted. So making sure that the height and weight are properly documented so we can get an accurate BMI. And then the abdominal exam is also helpful as a clinical dietitian, especially in the ICU or post-transplant, assessing if the patient's having any abdominal distension, pain, cramping with eating or with enteral nutrition. And then also we'll want to make sure that we pay attention to edema on the exam. So mainly for patients in heart failure, we usually have lower extremity edema. Also patients with end-stage liver disease will sometimes have lower extremity edema, but for those patients, we'll also want to look at their ascites. And then assessing neurological. So is the patient alert and oriented, able to answer questions appropriately? Is their strength equal on both sides? And this is where a hand grip can also be used to help assess strength in these patients when performing the nutrition-focused physical exam. We also want to make sure that any components of the nutrition-focused physical exam fit with the patient's medical history, their diet history, and also if any of the findings can be related to the transplant medications or for their disease state. So assessments of fat stores will exam around the orbital area, the upper arm, and the thoracic and lumbar area. For patients with ascites, the thoracic and lumbar area might not be accurate as the area is going to be skewed by fluid retention, but the orbital exam and the upper arm exam should be good assessment of fat stores in those patients, and for patients with heart failure as well that might be retaining fluid on their lower extremities. So just some pictures, the top left corner, this patient has normal fat stores, but underneath you'll see this patient has severe fat loss under their eyes, they're hollowing, and also dark circles. For this patient here, we see that he has experienced significant fat loss as well as muscle loss, and his clavicle is prominent. And for this patient, they have severe fat loss and the ribs are protruding, the iliac crest is present. And like I said, for patients with ascites, you likely will not be able to assess this area on exam. Assessment of muscle stores, we'll look at the temporal area, clavicle, deltoid, and scapula. For patients, for women, the clavicle is somewhat visible. So when I'm assessing the patient's muscle stores, I'll ask them if the clavicle is sticking out like for them normally, if they've noticed any changes over time. For men, you shouldn't be able to see the clavicle. So I will always ask a patient, are these how your muscles typically look before you became sick, or have you noticed a change recently? They're the expert of their own bodies, so they should be able to tell you if they've noticed changes recently as well. So just pictures of assessment of the muscle stores. You'll notice this patient here has severe temporal wasting as well as buccal wasting in the cheek. And then this patient has severe muscle wasting of the pectoralis major, as well as hollowing in the trapezius muscle and around the base of the neck, and the clavicle is very prominent. There's also deltoid muscle wasting, which you can be seeing in the sharp angle of their shoulder. And here's another photo of the deltoid muscle wasting where you can see the scapula is a little bit more defined and the shoulder is sharply angular. So additional assessments of fat stores will check the interosseous muscles, which could also be diminished as a sign of aging. So if you're assessing an older patient, that's something to consider. And then the assessment of the thigh, the patellar region, and the posterior calf. As I said, for patients retaining fluid and end-stage heart failure, that these areas of the lower body are likely not accurate, and I would try to focus on assessing fat and muscle stores in the head, in the neck, and the upper body for a more accurate read. And just to show that muscle wasting in the interosseous muscle, you'll start to see the muscles diminish between the fat and between the thumb and the forefinger. And this is a patient who's experiencing severe muscle wasting of the thigh. The patella is prominent, and also there is no calf muscle, really. It's not defined and you cannot palpate it easily. Just a note for a patient who might not be as physically active, you could notice that their calf muscles might be more diminished, but you should still be able to palpate some muscle. And then it's also just important to make sure that you're grading edema, especially for our patients in heart failure. So assessment of micronutrient deficiencies. The skin is examined throughout the nutrition-focused physical exam. We want to make sure that we're inspecting for any poor wound healing, edema, rashes, lesions, and turgor to assess hydration status. For patients post-transplant, immunosuppression, mainly the steroids, can affect wound healing for these patients. So if a patient is eating poorly after transplant, their surgical wounds are not healing, you're noting that on the physical exam, it can also have a component of the medications that they're taking. Hair, you want to assess for the texture, distribution. Has the patient experienced any loss recently? Good hair quality should not be easily plucked, and it should be shiny. For patients with poor hair quality, you want to consider, is there a protein deficiency, essential fatty acid deficiency, any zinc or biotin deficiencies? Of note, post-transplant and with some of the immunosuppression, mainly the tacrolimus, and can cause alopecia. So if you're seeing hair loss in post-transplant patients, that is something to consider as well. For eyes, you want to make sure there's not any inflammation around the eyelid. And for lips, tongue, and the oral cavity, you want to assess dentition. Are the patients going to have any pain with chewing? Are they have adequate moisture? Are there any lesions? Which sirolimus, after transplant, that medication can cause aphthous ulcers. So having that as a consideration when you're performing the nutrition-focused physical exam after transplant, and assessing for the color. For nails, you want to make sure that they have uniform thickness, that they feel smooth, and they adhere to nail beds. For patients undergoing lung transplant, you might see that the patient has clubbing prior to transplant with their nails. So just some photos of what you could expect with micronutrient deficiencies. So in the top left, this patient has chelosis, which could be a deficiency of vitamin B, of vitamin C. Down here, you see the spooning of the nails, which could be indicative of an iron deficiency with or without anemia. Glossitis, which is inflammation of the tongue. So this could be a vitamin B12, B6, or a niacin deficiency. And also for patients experiencing dermatitis, we want to consider, is it maybe a zinc deficiency or essential fatty acid deficiency for patients who are not able to maintain PO intake or have been NPO for an extended period of time. They might have dry, rash, itchy skin. So these micronutrient deficiencies we're not using them as a diagnosis of malnutrition, but they are supporting evidence when assessing the patient of malnutrition. So just briefly review. So I've been using the Aspen A&D methodology of diagnosing malnutrition, and we need the 6 characteristics. Within the 6 characteristics, we need 2 to diagnose malnutrition. So the nutrition-focused physical exam can help us diagnose or use as a diagnosis piece to grade the severity of the muscle loss and the fat loss, where this could be beneficial for transplant patients because the percent weight loss over time reported from a patient might not be accurate due to fluid retention. So a patient was diuresed or they had a paracentesis and they experienced significant weight changes. Those weight changes, we couldn't use those to help diagnose malnutrition because it's likely not the lean body mass loss, yet these patients are likely still losing lean body mass. It's just hard to differentiate that. And then the fluid accumulation is likely related to their chronic disease, so with their ascites or with their lower extremity edema. So using that as a diagnosis becomes difficult. So the nutrition-focused physical exam really helps us hone in on determining whether or not there's lean body mass loss. And you can measure just diminished functional status by using the hand grip strength, but just know that that's not accurate in mainly the ICU populations. So the transplant assessment, so CMS requires all transplant programs make nutrition assessments available to all patients undergoing transplant or living donation. And malnourished patients prior to transplant tend to have increased rate of post-transplant mortality and morbidity, longer hospital stays compared to the patients who are well-nourished before transplant. And the nutrition assessment includes a thorough nutrition, medical, and medication history, as well as a review of laboratory data, anthropometrics, the nutrition-focused physical exam. And some centers are also incorporating a frailty assessment at this point. So here at UCSD, we complete the frailty assessment for patients undergoing lung, liver, kidney, and heart transplant. We use the free frailty phenotype, and the hand grip measure is a part of that frailty exam. So our transplant nutrition goals. So each phase of transplant has specific goals. So the pre-transplant phase, our main goal is to optimize the patient's nutrition status to help them undergo transplant surgery. So this is really important where we want to identify the malnutrition, determine whether it's moderate, severe, and help to treat the malnutrition in a way to get the patients to transplant. And this is really important for cases we might have to utilize nutrition support. Some people are unable to meet their needs with oral intakes or use of supplements. So that's where enteral nutrition can be really beneficial to these patients, whether or not for some patients might require a PEG tube placement in case of patients with cystic fibrosis, or some patients might have a post-pyloric NG placed, and for liver transplant patients, that's utilized to help provide nocturnal feeds overnight in addition to PO intakes during the day. And then the post-transplant phase, so this is really right after transplant and 3 months after transplant. Our goal is to provide adequate nutrition to replete lost nutrient stores from the surgery or prior to surgery and heal those surgical wounds, as well as preventing infection, managing any medication side effects that the patient might experience. And then in the chronic post-transplant phase, so that's 3 months, and then for the rest of their lives, just making sure that we're ensuring adequate intake, managing any long-term complications like diabetes, hypertension, hyperlipidemia, and osteoporosis. So just general post-transplant diet considerations. So this is across the board for all patients. They'll be taking the immunosuppressive medications, and those medications have side effects. So those patients will be taking steroid medicine. So we know that the steroids will raise their blood sugars, delay wound healing, affect their bone health, and then also can cause some weight gain. So for those patients, we really want to make sure they're eating adequate amounts of protein, and then also supplementing with any calcium and vitamin D supplementation is needed, or making sure they're also eating adequate servings of dairy throughout the day. I tell people to aim for 2 to 3 servings of low-fat dairy. Those patients could also experience electrolyte abnormalities, mainly from tacro and the cyclosporin. So for those patients on those medications, we could see that their potassium could become elevated or their magnesium could become low, or from magnesium wasting. So we're constantly monitoring those lab values and educating patients on following either a potassium restriction or increasing magnesium containing foods in their diet. Food and drug interactions with the immunosuppression. So for patients taking tacro, we advise them not to take grapefruit, pomegranate, Seville oranges, or star fruit. Sorry, that's a typo. Those medications can inhibit and also cause the prograph to work too well in some cases, so affecting those patients' medications levels. And then also we teach our patients about food safety. So that's important to help prevent infection. So educating patients not to eat raw meat or raw fish after transplant, making sure that those foods are cooked to well done temperatures, washing fruits and vegetables well before eating, practicing preventing cross-contamination. So when they're cutting their foods, not using the same knife that they cut their raw meat, and then cutting their fruits and vegetables, and making sure they're practicing proper food storage. So organ-specific care, so for kidney transplant patients, malnutrition can be found in 40 to 70% of patients with end-stage renal disease. And the malnutrition is usually a result of multiple factors. So anorexia, protein and nutrient losses during dialysis, and just high catabolic state. The body weight and the BMI likely might not be accurate due to fluid retention. So always work with their their dialysis dietitian to determine their dry weight, or needs can be assessed using ideal body weight. So pre-transplant, these patients are usually maintained an electrolyte restricted diet as they're working with their dialysis dietitian. So low salt, low potassium, low phosphorus, fluid restriction is needed. And like I said, before transplant, we'll assess their needs using their dry weight. If their dry weight is not accurate, then we'll use the ideal body weight. For patients on dialysis, we want to make sure they're receiving adequate dialysis or protein intake. And then for patients not on dialysis, just supporting their kidney function, making sure that they're receiving protein from high biological value sources. And then kidney transplant, the patients are at risk for multiple vitamin deficiencies. So you want to make sure that your patients maintain on a renal multivitamin, that any iron that is supplemented with any iron or vitamin D, as those levels could be low. And then post-transplant for these patients, once their kidney starts to work, they might be able to enjoy a more liberalized diet. So for a patient that's been following a low potassium or low phosphorus diet prior to transplant, they might be able to eat those foods now. So sometimes we see people enjoying foods that they haven't been able to in a while. And then long-term needs, we just make sure that we're maintaining a healthy body weight, and those long-term needs return back to the needs of a normal adult. So prior to a liver transplant, malnutrition is also common in these patients, and the potential causes of the malnutrition are likely related to poor intakes from anorexia and the early satiety from ascites, malabsorption, and decreased fat absorption. They're also at risk for a multitude of vitamin deficiencies, so checking vitamin A levels, vitamin D levels, making sure that we're repleting them prior to transplant. Of note, for patients with Wilson's disease, we could see that copper levels are increased. Pre-transplant considerations. So we want to make sure these patients are maintained on a low salt diet, high protein diet, and then carbohydrate controlled as needed if their blood sugars are difficult to manage. Encouraging small frequent meals for patients with early satiety, and also the use of a bedtime snack with protein in these patients with liver disease. And the bedtime snack has been shown to help preserve more lean body mass than just eating during the day alone. For some patients, they might require the use of nocturnal tube feeds if they're unable to maintain their intakes with eating alone. estimated needs. So again, with these patients, we'll want to make sure that we're using their dry weight or ideal body weight if we're unsure of their dry weight, or if a patient has obesity. Providing adequate protein prior to transplant. Some patients might require up to 2 grams of protein per kg if they require repletion. For patients who might be hyponatremic prior to transplant, we will also want to make sure they're maintained on a fluid restriction. Post-transplant considerations, the diet recommendations are just as before transplant. We'll want to continue any enteral nutrition if they were maintained on it prior to transplant until we know that they're able to maintain their intakes by eating alone. And their estimated needs are a little bit higher, so 30 to 35 calories per kg of dry weight to help make sure the patients are being repleted after transplant. And for all patients undergoing transplant, if they're in the ICU, we really want to aim to initiate nutrition within 24 to 48 hours after transplant. So if the patient's able to be extubated and they can start to eat by mouth, ordering them for the diet, getting supplements, or maintaining enteral nutrition support as needed. For patients who are not able to be extubated, initiating enteral nutrition once they're hemodynamically stable to provide the patient with adequate nutrition. So for heart transplant, patients experience malnutrition, likely related to anorexia and nausea that's associated with their heart failure. The loss of the muscle mass in their heart can lead to reduced blood flow of their gut, which can cause delayed gastric emptying, and also edema of the bowel and stomach can lead to decreased appetite. We want to make sure these patients are maintained on a sodium-restricted diet pre-transplant to help with the management of any edema, and also the use of small, frequent meals can be utilized for patients with early satiety. We also want to make sure patients are maintained on a fluid restriction if they are hyponatremic. And if the patient is thiamine deficient, we want to make sure we're repleting thiamine, as low thiamine levels could lead to low cardiac output. So post-transplant considerations, just continue the low sodium diet, high protein diet as the patient is healing. It's important as they need to replete their muscle stores, but also the steroid medication will make wound healing more difficult. So we want to provide adequate protein during that time. The use of oral nutrition supplements, and our estimated needs initially right after transplant, once they're out of the ICU and they're on the floor healing, are a little bit higher to promote repletion. And then over time, they return back to the needs of a normal adult. So for lung transplant, malnutrition is common in patients with COPD. So up to 60% of them will experience malnutrition, and about 45% of patients in the outpatient setting with COPD will also experience malnutrition. Malnutrition is also common in patients with cystic fibrosis awaiting transplant. So causes of the malnutrition are likely related to hypermetabolism from just increased work of breathing, anorexia, and early satiety. And in the case of cystic fibrosis patients, pancreatic insufficiency will also play a part in their nutrition status. So for patients with cystic fibrosis and even severe malnutrition prior to transplant, we want to make sure they're maintained on a high calorie, high protein diet. And for patients with CF, if they're unable to meet their needs with intakes alone and use of supplements, requiring a PEG placement prior to transplant to help make sure that they're able to reach their BMI goals prior to transplant. Also for patients, encouraging the small frequent meals and any estimated needs. For CF patients, just to keep in mind, their estimated needs are about 120 to 150% of the normal general population. So for assessing needs pre-transplant, if a patient needs to gain weight, I'll use anywhere upwards of 55 to 60 calories per kilo to help make sure they're getting adequate nutrition. And our BMI goal for those patients prior to transplant is aim for a BMI of 22 with females and 23 with males. Then with CF as well, we want to make sure that the patients have fat-soluble vitamins on board, as they're at risk for a fat-soluble vitamin deficiency, and any use of pancreatic enzymes. The pancreatic enzymes will be continued to be used after transplant as well. Some of the vitamin supplementation, mainly the fat-soluble, could interact with some of the immunosuppression after transplant. So for patients with lung transplant and CF, we might hold the fat-soluble vitamins for a period of time, maintain them on a vitamin B/C complex, and then monitor those vitamin levels and replete as needed. Calcium and vitamin D supplementation for patients on chronic steroid use prior to transplant, and we also would use that in the patients post-transplant as well. And then the post-transplant, similar, we want to continue their high calorie, high protein diet, add a sodium and a consistent carbohydrate restriction as needed. For CF patients, the sodium restriction is not indicated. Also, a consistent carbohydrate restriction is not indicated after transplant. We would want to make sure that the patient, if they're having high blood sugars, we cover that with insulin, as the consistent carbohydrate diet might not meet their estimated needs. The use of oral nutrition supplements and enteral nutrition to meet their needs, will continue to do that after transplant as well. And for patients with COPD or ILD, IPF, their long-term estimated needs should return to that of a normal healthy adult. Okay. So if anyone has any questions.
Well, thank you so much, Courtney, and thank you, Dr. Mueller. What fantastic, very super comprehensive presentations. I really appreciate all the insights that you both shared, and for taking the time to join us today and present this information. We're now going to go ahead and transition into our Q&A discussion. Again, I do realize we're running a bit over time here, so I appreciate you all for hanging on with us. If you do have any questions for either of our presenters, they've both graciously agreed to stick on with us for a few additional minutes. So that said, go ahead and submit your questions, and if we can't get to all of them, we will be sure to follow up with all of you via email. Just as a reminder to everyone, to submit questions to both of our presenters, you're going to go ahead and use our Q&A feature. And again, that's going to be located at the very bottom of your Zoom navigation bar. And with that, I'll go ahead and turn it over to Mariana to facilitate the discussion. Thank you, everyone.
All right, hi, the great presentation. I just want to say so much information packed into this short little session. And I know both of you could have expanded even longer on both of the subjects, because you guys are just experts. First question we have is an easy answer. Yes, the presentation slides will be available for you to have. And for Courtney, we have a question. Could you describe the abbreviated nutrition focused physical exam that you do for your video or virtual visits?
Sure. So it tends to be a little bit difficult, but when I'm seeing the patient on the screen, I will ask them if they've noticed any changes to their muscle and fat stores, which I know isn't always super accurate, but they might be like, yeah, I noticed my clavicle sticking out a little bit. Or I noticed that my ribs are protruding more. So I ask them to see if they've noticed any of that. I will also ask to see their ankles and feet, or if they notice they're having any lower extremity edema. And then it's easy to assess on a video, or not always so easy, but you can usually assess for temporal wasting, any orbital wasting. I ask the patient to open their mouth, stick out their tongue so they get close to the camera. And then also for some patients, you can also see if they're having any clavicle wasting as well. And then I might ask the patient to raise up their arm and pinch under their arm, so I can kind of get a general sense. It's not perfect, but if I'm only able to see them virtually, at least it's some information.
Yeah, definitely COVID has made it a bit of we're innovating how we do nutrition now, for sure. Another question that was typed in earlier, I think is best for Dr. Mueller, because I think you touched on this. We had a question about sarcopenic obesity and how to determine if nutrition support is needed in the obese patient with quote unquote extra fat stores. And I think based on your slides describing the inflammatory changes to how our body is using its metabolites kind of speaks to this, that it's not just the fat stores. So you can expand on this.
Yeah, if a patient has sarcopenic obesity, of course, that's something that is developed prior to anything that you're doing. And your reason for nutrition support is going to be, it depends, what stage, pre-transplant, post-transplant, or long-term. But let's say post-transplant, you probably wouldn't use nutrition support unless for some reason they were going to be in the ICU for an extended period of time on mechanical ventilation. Many people in the ICU, older adults, many COVID patients, for instance, have sarcopenia. And that's almost beside the point. They're receiving nutrition support because they're on mechanical ventilation, because you don't anticipate that they're going to be eating for any time soon. And you're certainly not going to evaluate fat and protein stores in those patients as any kind of legitimate outcome, because they're so they have obligatory catabolism. Rather, you're going to be feeding them to prevent further infectious complications and to perhaps feed the acute phase, which might be reflected in decreased length of stay in the ICU, more rapid weaning from mechanical ventilation. So some of these body composition measurements, the sicker you get, they're not really something you're going to monitor, okay? You will monitor degree of edema and third spacing of fluid. Indeed, when they get better, they will mobilize the fluid, diurese, and lose weight. And that's good, even though it doesn't look good. That answers.
Thank you. Yeah, actually, the next question is about edema. Saying since the edema is so common for patients with end-stage organ failure, do you think it should be even included as part of a malnutrition diagnosis, or is there a way to distinguish edema related to malnutrition and that specifically related to their disease? I think Courtney touched a little bit on whether it should be included in the malnutrition diagnosis, why we're using the NFPE to look for muscle and fat wasting stores, but maybe Dr. Mueller, you can comment on the second half of that question.
Well, we're always going to look at edema as it relates to malnutrition because it distinguishes between simple starvation and chronic or acute disease-related malnutrition. People who are merely starving don't have edema, by and large. So right away you can sort of triage people to chronic or acute disease-related malnutrition, which is going to be most of the people you see. But it'll tell you, edema tells you gives you a pretty good measure of the degree of inflammation or the degree of organ failure. The more edema you have, the more acute and serious the heart failure, the more ascites you have, the more that the cirrhotic liver and the inflammatory process is more advanced. So edema is really an indicator of the acuity of the disease process. And it's intrinsically related to nutrition because they're not going to have an appetite. So right away, it distinguishes between uncomplicated starvation and disease and trauma-related starvation or malnutrition, you see? So it's a very important factor to sort of establish right from the get-go. I hope that answers the question.
Sounds good. And how about, I think for Courtney, this is a good question for you. The data about nutrition interventions on transplant outcomes, such as infection, hospital length of stay, readmissions, et cetera. Can you speak to your experience with this or what you've come across in your research?
I think that's a really great project too for each individual transplant center. So getting the dietitians involved in the quality council, the QAPI meetings, and having the dietitians assess for data for patients who are malnourished prior to transplant, or if they're frail prior to transplant, and determining their length of stay compared to patients who might not be malnourished, or how many days they're on the vent, or if they're developing infections, and then tracking that data to determine it with a nutrition protocol and early nutrition or early nutrition interventions if they're noticing a decrease in their numbers. And I think that's a great way for the dietitians to be involved in the quality council.
It's a really good point. We have to, make our status known in the team, and what we bring to the table. One question had to do with hand grip strength dynamometer, and if it has any value in completing the NFPE of a transplant candidate, especially liver and kidney transplant candidates. Dr. Mueller had a slide just kind of breaking down the different types of malnutrition, and it really seemed that we would only see changes with the hand grip strength with the severe versions of acute or chronic malnutrition. Is that correct?
Yeah, the best way to use hand grip is to use it over time. It's not a one-shot hand grip reading doesn't tell you that they're better or worse than they were. So if you get a hand grip, I mean, obviously you can place it within, you can benchmark it within normal ranges. You find a good benchmark set of data. But once you benchmark them, and let's say you benchmark them as being weak, you follow it over time for either improvement or diminished hand grip strength. And of course, you want improvement. So the best, in my opinion, the best use of hand grip strength is serially over time. One measurement might tell you something about that person at a point in time. You can benchmark it against the population, but you really don't know if that's an improvement or a decrease in their hand grip strength relative to when they weren't malnourished or sick.
Mariana, we use that in the frailty assessment. So the hand grip is being taken at that point at the initial assessment, and we'll determine if the patient, the frailty is strength and malnutrition. So we'll assess it. If it's a weak hand grip, we typically try to monitor every 3 months if the improvement. So once the patients maybe go into pulmonary rehab or work with physical therapy, then we've helped address the malnutrition to see if we've noticed an improvement with that. So I know we use the frailty assessment and the hand grip for that portion.
Great, good point too, because that is, in addition to malnutrition, frailty is definitely a hot topic nowadays.
Yeah.
Frailty goes hand in hand with sarcopenia.
Yeah.
They're almost they almost are the same thing in older adults, and it sounds like Courtney uses it serially in those patients, in that group of patients.
Yeah. Open to either of you to answer. The NFPE in obese patients pre and post transplant. I think what this question is, do you have any difficulties with it, interpreting it, or any barriers that you find that maybe are masking malnutrition with their obese status?
Mm-hmm.
Well, I'll let Courtney take this one.
So for these patients, I think a barrier pre-transplant could be if they're having the fluid retention, right? So for patients on dialysis or heart failure, I had a patient just the other day who in liver failure, and his BMI is 31, yet he had, moderate temporal wasting, he had moderate clavicle and scapular wasting. So we see there that even if his BMI is in the obese category, he's still having a degree of malnutrition. And for patients where it's difficult to manage, I think some centers are also using CT scans to assess the lean body mass versus the fat mass in those patients to help make a decision on whether or not they could be candidates for transplant. As we know, like the BMI and that marker isn't always accurate.
The next question is there a difference in the frailty test for abdominal versus thoracic patients?
So with the frailty exam, we use the Fried frailty phenotype across the board for all of our organ, but there are different frailty assessments that can be used. It just depends on the center that they want to, which frailty assessment they want to implement. we just use the Freed frailty, so can't speak to the other frailty assessments.
Yeah, Freed is the most widely used one. And there isn't consensus in the geriatric community on how to assess frailty. It's one of the things that's all over their literature, but I think if you chose the Freed, you're using the one that is used most commonly. Yeah.
Same. I just gonna weigh in with my experience too. Yeah, I found the same in the literature. There's some other tactics that you can use for the liver transplant patient or the liver failure patient that has been shown to be useful in a different way than the Freed frailty. But I think we're going to have to wrap up for today. I, of course, am available for any questions that you guys want to forward. If Courtney and Dr. Mueller are okay as well. I believe they have their contact information available, and then Deanna too.
Great. Thank you, Mariana. Yeah, as she said, feel free to forward any questions. If you have additional questions that you'd like us to address or our presenters to address, feel free to send them to the Alliance, or if you want to contact anyone directly, I'm sure Dr. Mueller, Courtney, or Mariana would be happy to assist. But with that said, I'd just like to extend a sincere thanks on behalf of the Alliance to both Dr. Mueller and Courtney for joining us today. Again, both of your presentations were so comprehensive in nature and provided such a fantastic overview of nutrition-focused patient exams. And so we appreciate you taking the time to join us and staying on a little extra longer to address some of those questions. So thank you both. And additionally, I'd like to thank Mariana for your efforts in facilitating such a fantastic and, again, informative discussion. Thank you all so much for your time. And of course, to our participants, we thank you for joining us, and we look forward to seeing you again in the future. Take care, everyone, and stay safe.
Thank you. Bye-bye.
Thanks so much, guys.